ever cared.
Hello again, I'm Dr. Hung Vu, and our show is America's Healthcare Crisis. Welcome to our second segment on the quality issue in pediatrics. During our first segment, we began to discuss the aspect of prevention. So I'd like to welcome our speakers back to elaborate a little bit further on the issue. You said that one of the aspects of quality in pediatrics is prevention. Can you say further about that?
Well, one of the things that it takes to be able to prevent disease, to understand people and their families, children, is that you have to have some time to talk with them, to listen to them.
Okay.
And this is one of the problems that exists with prevention, is that people and insurance in general have been reluctant to pay for something when they don't feel bad. And yet this is where we really should start putting more of our resources, more of our time, and helping people prevent problems, helping them develop maximally rather than just simply treating disease.
Yeah.
You know, it may be, as you said, Hollywood-ish to rush in and save lives and, you know, do Dr. Kildare splenectomies on the side of the road and that sort of stuff. But really, if you look at what comes out of it, that probably the most bang for the buck is in the preventive aspect and the child development aspect, which is a very important part of pediatrics.
Yeah. You know, in my own experience, I felt that when I understand the patient and the family and the social structure around them, and the best time to understand them is when they're well.
Right.
Then it will be much easier to take care of them when they're sick. Sometimes we can take care of them on the phone, you see. But I think that we do things very inefficiently because we do crisis intervention. You know, we are good at that, but I don't think it's nearly as cost effective or even good to do that.
Well, one of the good parts about managed care, some managed care at least, is that we're able to actually sit down with each other and learn how different doctors approach problems, learn from each other, and we are putting more and more emphasis on prevention for two reasons. One, I guess, is the bottom line dollar, it pays off, but the other, of course, is that it's our profession, and that's what we're really here to do, is to help people stay healthy, not just simply go around stamping out disease.
Right. For example, I remember when I was still involved in neonatology, is that at the University of Colorado, which was really the forefront of the field, they had a team that has a coordinator who went from the delivery room out to the waiting room every 5 or 10 minutes to communicate with the parents. And I thought that was a very good process because the communication part is so important in terms of preventing even misunderstanding and malpractice and so forth and so on. May want to come
I think we've come a long way that way. You know, initially in intensive care units, we had the parents wait outside all the time until we finished working with their baby. Now, very seldom are the parents asked to wait outside. Most of the time the father's there when the baby's born and watches you. We resuscitate the babies right in the room where the mother is if it's a vaginal birth. And we do try to educate the parents as we go. We try to let them know what's going to happen ahead of time if possible, unless it's something that's happened very rapidly. And we want the parents to understand everything that's going on with their baby.
Make them participant of the process instead of the receiver of the whole.
One of the reasons we have to do that, is that the baby is being pushed to go home earlier too. We neonatologists, we tend not to keep them in the hospital because it is so expensive. We send them home earlier, and if the mother has become the primary caregiver, she's the one that really coordinates the baby's care, even if the baby goes home on oxygen and a monitor and so on. The whole family's going to do a lot better.
But the psychological impact of this is very important too. They see the amount of effort that you and the nurses and technicians put in, and it really raises the value of the baby in a sense. I mean, it sort of confirms that this is an extremely valuable individual, and hopefully from there on in they'll take that and run. And it's interesting to me that the babies that I see who've undergone problems as neonates and have had sickness, that the parents often, I think, value them more, but unfortunately sometimes worry about them more.
Well, I think all parents value their kids, but these are expensive kids. There's no doubt about it. And a lot of the problems come that we sometimes don't bridge the gap between hospital and home all that well. A lot of these kids need ongoing services, which are not as easily available as they should be. They need home health, nursing, and so on. Those are more difficult to get now.
We're seeing the babies now when they come home from the hospital the next day. Of course, this business of getting babies out in 24 hours or less is not the best thing in the world, but we see them in the office sometimes 1 or 2 or 3 days just to make sure that everything is fine if we have any real concern.
Yeah, there are good things and bad things about getting the kids out of the hospital earlier. And don't get me started on drive-through births. I saw a cartoon in the Pediatrics publication the other day where there was a parking meter by the bedside of the mother and baby, and at 24 hours the parking meter went off, and there was a spring-loaded bed, and they were kicked out of the hospital.
That's probably a bit cynical, but I one thing I have learned during my whole lifetime of practice is that I believe in being a coach to my patients, not their doer or their even their doctor, because even though it's not financially rewarding sometimes, because you're not rewarded for helping them that way, but I feel that's the best way to practice, is because you really have to give them the tools, because you only see them once a month, once in 2 months, and at the rest of the time they have to rely on their own resources, and it's a matter of sitting down and give them the tools and explain to them the resources that are available, among which is their own family or their own. I mean, the more they understand the problems, the better they take care of it. And I believe that realistically, eventually, we have to move toward compensating that kind of skill, being a coach and not a doer.
I tell the mothers on their prenatal interview that I'm a coach, not a captain, and that the mother is the captain of the team. And that's the way it should be. They're going to know that baby better than anybody else. As a professional, I can offer them advice, but that's one of the things that's sort of worrisome about quality care is, one man's quality is another man's catastrophe. If what I tell parents to do is ride on 999 kids out of 1,000, that's great, except for the 1 out of 1,000. And in fact, I tell parents that I can't tell them everything to do from here to college and back, that they are going to be responsible, and they're going to have to really use their heads, as they would if they were out alone someplace in the woods and they had trouble with a baby. They would experiment around till they did something right. I think we take something away from parenting by trying to impose ourselves on them too much.
And I think part of the danger of technology is that it gives the patients unrealistic expectations.
It sure does.
In other words, they think that they can have a problem fixed within minutes by a God-sent all doctor, which I think is very unrealistic. Most problems are very complex, and I think that I feel that in many cases, if we really know how to encourage or motivate people to take care of themselves and give them the confidence to do so, I think it's in my opinion, it's a better medical care than codependency, and it's also more cost effective also.
Well said.
Now, I understand that, I'd like to mention here that both Dr. Conom and Dr. Austin involved in the politics of medicine. Should I say, Dr. Conom is the president-elect of the Santa Clara County Medical Society. She assumed her function as president within a few months. And Dr. Austin was former president of the American Academy of Pediatrics. What is on the agenda of the Academy of Pediatrics at present?
Their agenda? Well, it's still essentially being an advocate for children, and one of the ways that they're now practically advocating is by trying to improve insurance coverage for children for newborns and straight on through, especially emphasizing the preventive care. They have many programs like how to prevent accidents, how to reduce poisoning. It's a very worthwhile and I think fairly effective. I've noticed in my practice lifetime that the number of children that we have hospitalized has gone down tremendously, dramatically. And the number of children that I see and have to treat for poisoning now is hardly any, because I make certain that every child, every toddler family has a bottle of syrup of Ipecac on hand, so they can give the baby or the toddler something if he happens to ingest a poison, and he'll vomit it before he becomes poisoned. The trip to the hospital or the emergency room is a time for that poison to be absorbed. And so by doing something this simple, you can really reduce the cost and the amount of illness and the problems and the sometimes delayed real serious problems that children have from poisons and accidents. So that this is part of what we're doing. Like the Academy pushed for car seats for babies, and we had a program that took us a long time, but we finally got it to where it's a state law.
Maybe with capitation, that process would be enhanced. In other words, you can be compensated for spending time preventing problems, and it's more cost effective that way. And if you wait for the child to get a serious accident or poison by some kind of serious products, then it costs much more to take care of them. So don't you think that with a managed care capitated kind of program, we have more funds for that kind of?
As a matter of fact, one of the good things in managed care, and there are a lot of bad things, I think we all agree, but one of the good things is that we are beginning to emphasize prevention. In our own IPA, that's Independent Physicians Practice Association, we now make certain that every family gets a bottle of syrup of Ipecac to take home. We make certain that we pay adequately, well, if not adequately, at least we pay better than we used to for the preventive care versus the sort of recurrent runny nose care. In other words, we're trying to put the money to work in a better way than it has been in the past. The difficulty is we don't have quite enough money to do all these things.
Needless to say, the vaccinations, for example, was a big turnabout in terms of infectious diseases, wasn't it? Because with the vaccines, we cut down all the problems with measles and smallpox and all that. And nowadays, we have all the problems to prevent. Poisoning accidents, which are very high in the list of pediatric catastrophes, we may say, and other things that I think makes perfect sense to spend money in that area.
Yeah, it's interesting that we've almost achieved a fairly efficient way of protecting and helping kids during the first 10 years of life, but when they hit adolescence, we have an entirely different ball game.
Okay, let's talk about adolescent medicine now. You touched on that. Now, I'm not a cynic, but I think that the three major problems with teenage is sex, drugs, and booze. And I think let me quote the president just mentioned in his State of Union speech that it's very difficult to be parents. It's harder to be children, and it's even harder to be pediatrician, maybe.
Well,
caught in the crossfire,
Yeah, actually, there are a lot of things going on as far as taking care of adolescents, and certainly sex and drugs are all there. What the real, probably bottom line is a sense of American values. And also the way that Americans parent. Now, for a long time, it was thought by some of the psychiatric community that adolescents should be given an extreme amount of freedom, that this was the best way that they could develop. The only really solid scientific evidence that has come out is a 30-year study by Diana Baunrein at the University of California, where they watched children and the way they were raised for 30 years without interfering and measured what happened to the children and what kind of parenting they had. And it turned out that the parents that were the strictest with their adolescents, that the adolescents as young adults and as really future citizens were far better off than those that were given all of the freedom. In other words, you have to demand a lot. And I think one of the people worry so much about adolescents rebelling, and certainly they do rebel, and it's a natural kind of thing. But if they're allowed to rebel and take off, they do some pretty stupid, silly things, the drugs, the sex, and the rest of it.
Is that one of the quotation from psychological philosophies that they feel that if you don't set any limits on them, you don't love them enough? Is that it? If you really love me, you set limits.
That's right. Well, tough love says set really tough limits. That's correct. But the practical thing, so many of these things are theories, and everyone has their own theory about child raising. And the difficulty is that because someone has a degree behind their name, or because they're a doctor or a psychologist, you have to listen to them. A lot of the stuff that has come out is pure poppycock. It's a matter of actual fact. And basically, more and more people are finding that Baumrein's work has been duplicated, and it turns out that, again, that parents who will listen to their children, who will respect them, but at the same time give them firm direction and are really involved in their lives, now these kids do fine. If parents are over strict, authoritarian, they don't do as well. And if parents are permissive, the kids do very poorly.
Right. That's what I'll say. You have 2 children?
Yes, I'm listening because I have a 13-year-old boy.
How old are they?
He's almost 13. I have a son and a daughter that's almost 10.
10, I see.
So,
do they have their own pediatrician?
oh, certainly. I've never examined them myself.
By what criteria did you choose their pediatrician?
The person who I got along with myself the best. The person whose style I thought that I could
that you could really
best deal
communicate with.
Yes.
Yeah.
Yes.
So,
And I knew that I would overreact to everything. And, you know, if they got a fever, I knew that I was going to watch out for meningitis, and I knew all the bad things that could happen. And so I got a pediatrician that was very low-key and would just basically reassure me that statistically the chances of them going on to being very sick were very low. And in fact, I was in premature labor for 3 months with my second one, so I know what it means to be on bed rest, and both of my kids were a month early. And so I went through...
So that's how you got into neonatology?
No, I was in it before that, but I can certainly sympathize now with the mothers. I know a lot about breastfeeding preemies because I did it. And there aren't too many neonatologists around that have done that.
Not bad.
And so, you know, I think that you see things a lot differently once you have your own, of course.
You know, from my own perspective, after 25-year practice, I just realized that for me, probably the most valuable skill is the ability to communicate in such a way that that is not just talking, but share information and how to. One of the things, for example, I think that is not taught in school is how to use information wisely. In other words, you can go to a computer and punch out a bunch of information, but how to put them together so that it can be a guidance for your action is something that we don't learn in school.
We know that's true, and at this business of communicating is partly listening. And certainly one of the problems that we have in adolescents and treating adolescents is that we sometimes don't have time to listen. And if you sort of zim-zam move them through, they don't think that you really care particularly. And if you do spend the time in managed care, someone comes down on your back and says you're spending too much time, you've got 15 minutes a patient. And this has to be avoided. Somehow adolescents should have a doctor that they can really communicate with, someone they can trust. And they can't, I can't fit every adolescent's personality or vice versa, just as a pediatrician can't fit every mother's needs. But there has to be the time and the energy and the resources put into this if we're going to ever make a real impact on reducing these things. You know, adolescent drivers, for instance, in the first 3 years of driving, kill 3 times as many people as all the other age groups put together. And you know, this is something that you can actually have a slight effect on. I don't know how much of an effect, but you can warn them, get them to see that they need to be careful, that they don't have to rush out there and get the most souped up car they can. Some of them will do it anyway, but you can actually reduce the problems.
Yeah, you know, to me, you know, the biggest challenge for me in terms of being a physician is how to, within a short period of time, say 5, 10, 15 minutes, inspire the trust and the respect for my patients. I think that is something that you cannot learn in school. That is a composite of so many things. You know, I mean, if you can inspire that, that's very good. And anything else you do may be just supplementary.
That's probably true. And the interesting thing is that if you can get an adolescent through an episode of mononucleosis or something, which you probably would get through anyway, with or without our help, but sometimes we can be quite helpful. But the very fact that we cared, and the very fact that we tried, says that, you know, we really are on your side. And that's when the trust comes.
Right.
It isn't always just in a sit down and tell me all about yourself. Most adolescents go, you know, like this. They don't respond to that. You have to have a different kind of an approach.
And it's disconcerting to see that, you know, they don't have too many role models, you know, to look up to. You know, they look at all those movie stars and those athletes stars, and they think those are the people they want to be. And whether it's really beneficial for themselves or the society is something else. And I think that we talk about values, and I think that it's refreshing for me to hear many people, including adolescents, who say that their role models are their parents. I think that would be very fortunate if we have a society in which most of the role models for their children are their own parents, you know.
That's right. And actually, you know, the single parent is the one I feel sorry for, but the kids of single parents turn out more poorly, basically, than the children of intact families. And I think that this is part, again, of the American problem, that everyone does what they want, whether it's good or bad for the rest of the group, the family. You know, do your own thing. And it's been carried away. I think it's going to have to change.
You know, there's a term, family-centered care now. I think that's what you're really talking about, the art of taking care of the patient in view of what's going on in the rest of the family. That's very important in neonatology, too, as you can imagine. I just thought I'd bring that up, in that a lot of people think that we're taking care of this very premature infant on the basis of some protocol or some, you know, preconceived idea of what has to be done for every baby that weighs so much and that has certain problems. But really, we try to put that together with what the family wants us to do. And there have been articles in women's journals sort of talking about how the neonatologist just basically does what he or she wants to do with the baby, and the family loses control. And that is really not what goes on. We talk many, many hours with families about whether or not they want certain treatment for their baby. We often face situations where we may stop life support, but we spend a long, long time trying to figure out what's the best for the whole family, as well as the rights of the child have to be considered. But
give me a quick view on the pediatrician's perspective on sex education.
Well, sex education alone doesn't seem to do an awful lot of good. It's certainly reasonable to let them know about the problems that exist if they don't take care of themselves. They have to teach them that there are tremendous numbers of venereal diseases, and that there are tremendous problems. Ask them how they would feel if they were an unwanted baby. This you can do some things on it. But again, they're so bombarded by television sex and by movie sex, and then people seem to keep pushing them more and more. And it's interesting that a lot of the kids really don't want it. And I think that, that again, it's something that pediatrics alone isn't going to solve, or even on a one-to-one basis. It's going to take, again, social values. And I think that maybe America is beginning to move back towards a more, possibly because of the AIDS epidemic and other things, toward a more conservative viewpoint.
Yeah.
It used to be that father would get a shotgun out if his daughter got pregnant and they got married, because if they didn't get married.
Seems like we swing from one extreme, the Quakers, Puritanism, toward the liberalism of the 60s, and now with the AIDS, you swing right, hopefully you're in the middle.
I've always been impressed by the way that the kids that were brought up in this sort of libertarian atmosphere have become very conservative as they get older.
A lot of us, yes, from the 60s have become conservative.
I guess I should quote the British saying that you can count on the Americans to eventually do things right after they have tried everything else.
Well, did you hear the one that Churchill said, that you're not civilized till you're at least 25 years old? He's right. I guess maybe part of our job is to help them move toward a little bit towards being civilized.
Yeah. Well, I believe that the pediatric field does have a lot to offer, and I certainly hope that you will continue to give us the guidance that you have been doing all these years in your fields, because I think it's very important to have everybody listen to voices like yours instead of all the disturbing TV shows that we have all the time. So again, time has passed by very quickly. You see, it's not that big of a deal. And I really appreciate you being here and sharing with us your experience and knowledge on the field of pediatrics. And I certainly hope that this will give our audience certain food for thoughts. And again, I'm Dr. Hung Vu, and our show is America's Healthcare Crisis. You have been watching our two guest speakers speaking about the quality issue in pediatrics. This is part of a series of shows where we'll be profiling the champions in their field of expertise. The next show will be, I believe, in dermatology. So thank you for watching. I'm Dr. Hung Vu. Good night. So long.
Do you need someone to always be near? Do you have someone to stay through the years? Let me be the one, now that I am here. Let me be the one to be there with you through the hail and snow, so our love will grow. Let me be the one in the morning sun or the pouring rain. Let me be the one. Let me be the one to hold you tonight, always by your side through the rain or shine. Let me be